that.
So you're recording it there, but I don't know if I can record it, if you record it yourself there. I think I can't. Okay, so you're recording it, that's fine, then I can get it from you. So anyway, yeah, I'm Dr. Halasa, the founder of Chronic Disease Prevention and Management, and we are looking for any innovation, any trend that we can use it to redefine medicine. Dr. Joseph James is the one who brought this molecule when we are talking about oxytocin and Benadryl. He said, well, there is a molecule that stabilizes the mast cell, and it has many other qualities, and it's being used in Japan, and it's FDA approved for oral ulcers, and that's it. And then in certain ways, it's being discontinued in the United States for no reason, except they say they find better medication for mouth ulcers. But then there's a lot of investigation happen with this drug, and now there's form of oral tablets. It's being dispensed here in compounding pharmacy. Dr. Mike Beamer, Amex Pharmacy, has carried this drug in the form of 40 milligram dose, and it has many good healing effects because it has many targets and critical targets in our biochemistry, and it helps to restore a lot of the pathological pathophysiology by targeting those critical enzymes in our body. And as you see, it's a new trend of medicine, I think, and it has the potential to manage and prevent chronic disease across all medical specialties. That's how big this molecule. That's mean I can use it for degenerative disease, autoimmune disease, allergies, cancer, and you'll be surprised why that this drug can be used for all this chronic inflammation, degenerative autoimmune cancer, and also genetic diseases. And that's the beauty of this drug, that other drugs that we know that they don't really touch anything genetic, but this drug does. And the way it does help in managing genetic diseases is that those 30% of genetic diseases because of mutation, we call them nonsense mutation, where we have abnormal stop codons in the reading of the DNA of the genes. And those messenger RNA, when they have the stop codons, and those stop codons, I think there are 3 of them. And when I was teaching in college, I was trying to simplify it for the students. And the name of those 3, it's you are gone, you go away, and you are away. And those are abbreviations for you are gone, UAG, you go away, UGA, and you are away, UAA. So those are stop codons where they don't have any, cannot be translated into any amino acids. And it happened that the genes of those 30% of genetic diseases, they have this nonsense mutation, the stop codons in the middle of that messenger RNA of that specific protein. And so when the DNA is being transcribed into messenger RNA, you will see that stop codon in the middle. And there's enzyme, it's called NMD, and it's nonsense messenger RNA mediated decay, which is enzyme that finds those nonsense codon and those messengers of RNA, and they just destroy them. So those messenger RNA will not be translated into a protein, and you end up with of a missing protein that leads to that specific genetic disease. Let's say one of the example is cystic fibrosis, right? And we know that the missing genes is the chloride channel genes that produce the protein for the chloride channels, right? And what happened is that we can treat cystic fibrosis, which is a genetic disease, by giving amlexonax, because it will inhibit this NMD enzyme that breaks down those messenger RNA that has the stop codons. And doing that, I can produce, again, those missing protein, and I can reverse the pathology of cystic fibrosis. This is just an example, but almost 30% of genetic disease there are nonsense. And that is going to be another talk. I think it's going to be the session 2 of Amlexonax. Session 1, we're going to talk about how Amlexonax modulate the immune system by blocking enzymes, which is it's called the NFK beta or NF kappa B. And NF kappa B is an enzyme that that express the pro-oxidant enzyme, like NOx enzyme, and generate the free radicals. And generating the free radicals is behind all the degeneration and inflammation. So think about this enzyme will put the fire down, and neutralize, in other words, stop the production of those excessive of those free radicals, means that all the inflammation will go down, whether this inflammation is Th1 mediated, Th2 mediated, or Th17 mediated, because we know that there are 3 kinds of inflammation. So because of that, we can use it to manage almost any chronic inflammation, any neurodegenerative disease, any autoimmune diseases, including allergies, because it's also mast cell inactivation. In other words, it stabilizes the mast cells, so it's inactivate the mast cells. And definitely this drug can be used in all kinds of inflammation, whether it's Th1 or Th2 or Th17 dominant inflammation. We know Th2 is the allergic, Th1 is the cytotoxic T cells mediated autoimmune diseases, like systemic lupus or like multiple sclerosis or rheumatoid arthritis, or it could be Th17 mediated like psoriasis. All of these can be inhibited by this Amlexonax by blocking the NFK beta. So it definitely can be used to manage also cancer, because cancer can also be due to nonsense mutation of the genes that leads to turning those cells into cancer. So there's many cancers that can be treated with Amlexonax, and there's a lot of studies about them. And that will be the session number 2 of Amlexonax. So that's the new about this drug. I don't think, since I study medicine, and I think everybody here did not hear about a drug that helps to increase the expression of mutated genes. As a medical doctor, and I think all of us in the same, so this is kind of a new door that's been opened, that we have some solutions for those hard to treat cases, especially those genetic diseases, including cancer. We can reverse the abnormal mutation that's happening, that is the root cause of turning those cells into cancer by inhibition of NMD enzyme, and by reversing the mutation back to normal, where they can express that missing protein that leads to the whole pathology. And so because of its quality and mechanism of action, inhibiting NFK beta, inhibiting the mTOR, and you can see in A4M, they talk a lot about mTOR, although mTOR is not really the upstream enzyme or genes. The reality is that AMPK is more important than mTOR. I don't know why in A4M they entertain mTOR a lot. mTOR is actually inhibited by AMPK. And mTOR, when they are stimulated, they stimulate stem cell differentiation, proliferation, but also stimulate the cancer as well. So it stimulates the growth. And inhibiting mTOR leads to autophagy. And so it's very important when you are treating cancer or treating inflammatory diseases, you inhibit the mTOR to stimulate the autophagy. And who's controlling the mTOR is the AMPK. So AMPK, it's very important enzyme. It's a kinase enzyme that turns the enzymes, or turn the enzymes off and on by adding phosphate group to it. That's how they work. It's the kinase, right? So versus phosphatase, removing the phosphate, this is adding the phosphate. And MPK, we're going to talk about it. It's a very critical enzyme that mediates almost all the action, like fasting and exercise. It works through activation of AMPK. And once you activate the AMPK, you end up increasing the mitochondrial function and biogenesis, and you increase the glucose uptake, which is insulin sensitivity, and you end up with weight loss. You end up with lipolysis, beta oxidation of fat, which means that by activation AMPK, you can manage all metabolic syndrome. We know the metabolic syndrome, right? The weight gain, the atherosclerosis, the diabetes, the hypertension, right? And just by activating the MPK, we can manage the metabolic syndrome. Now, I said that this molecule works like steroid, but without side effect of steroids. And that's a very important statement. I need everybody to understand it as a doctor. So Amlexonax does inhibit the COX and LOX enzyme and does inhibit the NF-κB, but what it does, it stimulates the AMPK. Now, steroids, it does the same thing. They inhibit the NF-κB, which means they put down the free radicals, right? The NOx enzymes expression will go down and their activities. So you don't have much of free radicals. The inflammation will go down, the NOx and LOX will go down, right? You don't have those prostaglandins and all those leukotrienes and things that turn the inflammation on. So this is steroids, and Amlexonax does the same thing, right? But what's the difference? Here is the critical, important point, is that steroids inhibit the AMPK, and that leads to metabolic syndrome, while Amlexonax activate the AMPK. So that's the difference, and it's very important to know that. So that's the reason why steroid is good for acute conditions, but when you use it chronically, you end up with oxidative stress because it inhibits the AMPK, which is mean if you want to use the steroids, will be good if you add polyphenols or Amlexonax, which help to activate the AMPK and reverse the side effects of cortisone. But we find out that Amlexonax can replace steroids in almost every application of steroids, especially when it comes into chronic, okay? I'm not saying that the dumping effect or suppressing effect of the steroid is way higher than Amlexonax, but still it can be replaced because it does suppress the same enzyme that steroids does, but not in a severe way where it will lead to atrophy, but enough to manage those conditions, but without the side effects of steroids, which is blocking the AMPK. So those terminology of AMPK and kappa beta, those are very important. mTOR, which AFRM, they like to talk, those doctors of AFRM, they like to talk about it. It's downstream. Yes, it's important to inhibit them if you want to induce autophagy, but at the same time, we need to stimulate them if we want to stimulate the stem cells, right? But if you want to treat cancer, you need to inhibit the mTOR. But you can argue that inhibiting mTOR is very important for anti-aging because this will lead to autophagy of the senescent cells and inflammasomes. And we know the senescent cells and inflammasomes, they secrete interleukin-6, which inhibit the stem cell proliferation. Let me just close the door here. Okay. My kids are playing. All right. So I think I just gave a very big introduction about Amlexonax. I'm trying to break it down, simplify it, and before we go through all the slides, so you can be prepared that this is very important molecule, and it does gives us an insight about other other pharmaceutical products like steroids and other drugs, right? So Amlexonax is a small molecule which has been used in treatment of atopic condition, and I think they're using it for oral ulcers. Aftas, and previously, but it's not currently available in the United States. They discontinue it because they said, well, there's better drug for Aftas ulcer, for those oral ulcers. But in Japan, they continue using it, and then they develop from it drugs for asthma, and they have clinical trials for it, which is very successful. And the safety of the drug, it's very phenomenal. I mean, it's very good. Amlexonax has also been legally utilized and administered in Japan as a treatment for asthma because it's a mast cell activation, it's a mast cell stabilizer, and it inhibits the inflammation, right? It inhibits the Th2 inflammation and Th17, and those two inflammation, Th17, Th2, are mediating the asthma. And also, it's being used for chronic pulmonary diseases characterized by inflammation of the lower respiratory tract, right? You can use it for even obstructive diseases, COPD, chronic obstructive pulmonary diseases, because it does help to suppress the inflammation, same like cortisone, without the side effect of the steroids. That's the beauty. Why? Because, as I said, it activates the AMPK. So Amlexonax is an immune modulator. I don't want to say it's immune suppression because the users of those drugs does not have risk of having infection and cancer like steroid does. So steroid does suppress the immune system, does suppress the Th1 too much, to the point it compromises the immune system. Amlexonax does damp the immune system. So it's immune modulator effect, and has been subject of study, which has repurposed the drug for potential therapeutic potential in metabolic and inflammatory disease. So I can use it for weight loss, for diabetes, for hypertension, because it activates the AMPK. So it's good for metabolic, and also it's good for inflammatory because it inhibits the NFK kappa beta, right? Okay, NF kappa B. And doing that, I can use it for treating inflammatory disease. But in addition, it doesn't have the COX and LOX enzyme and NOX enzyme as well, like the steroids. So this is the molecule, how they look like. And this molecule is being FDA approved for oral ulcers, right? And now they find better drug. You can use methylene blue for that. So the clinical application of Amlexonax, because Amlexonax inhibit the tank binding kinase 1, which is the TBK1, and the TBK1, and also to inhibit the nuclear factor kappa B, and both of those kinases inhibit the NFKB, right? What's important is the NFKB is inhibited by those TBK1 and IKK. They are kinase proteins, right? And how they inhibit, they add a phosphate to the other enzyme, and that enzyme will turn off. So they are kinase proteins, and they have many names, but eventually they inhibit the NFK beta, or an NF kappa B. That's important enzyme, right? Several studies have demonstrated that the usefulness through its evidence down regulation of the immune system. Once you inhibit the NFKB, you decrease the activity of the NOX enzyme, and you suppress the production of the free radicals. And when you do that, the macrophage will the maturation into M1 or M2 or M17 will be suppressed, because in order for polarization of those macrophages and lymphocytes, right, and turn them into active, they need to have free radicals. And if you have too much of inflammation and too much of active macrophages and too much of Th17 or Th2 or Th1, all of this will be suppressed just by decreasing the free radicals inside them. And also those enzymes, which is the NFK beta, are responsible, and NF kappa B are responsible for expression and stimulation through the free radicals of all the cytokines, whether those cytokines are for innate immunity, interleukin-1, or interleukin-6, or interleukin-4, or interferon gamma. All those cytokines expression depend on the activation of NFKB. So if you inhibit that, you inhibit this, you suppress the whole immune system. I like to say dumping the immune system, but not suppressing it to the point it compromises the immune system to to compromise the immune system against cancer or against infection. So that's a very important point that we need to learn from here. And so I can use it for all kinds of inflammatory conditions, including asthma, including rheumatoid arthritis, multiple sclerosis, systemic sclerosis, whatever, all those inflammation, all those neurodegenerative diseases. I can use it for metabolic, for weight loss, for diabetes, for hypertension. And so if you see here how the Amlexonax blocks the TBK1, which is the FUS kinase enzyme, right? And how this will, of course, this kinase is stimulating the NFKB, right? See here? And so if you inhibit the TBK1, you inhibit the NFKB. And if you inhibit the NF-kappa B, you inhibit the cytokines expression, the free radicals, the NOx enzyme, the free radicals. And free radicals are very important to stimulate the expression of those inflammatory cytokines. And those inflammatory cytokines, including interleukin-1, interleukin-6, interleukin-4, name it, all those can be suppressed or damped by inhibition of NFKB. So Amlexonax eventually inhibit the NFKB through inhibition of TBK1. And they are just kinase protein. How they do that, they add the phosphate group to the NFKB and that turns it on. Versus phosphatase enzyme, they remove the phosphate group, and then the NFKB will be activated. Okay, and if you see here, let's say this is a macrophage, right? And this macrophage, how they get activated? Let's say they're activated by bacteria, lipopolysaccharides, right? So macrophage eats the lipopolysaccharides. This is the toll-like receptor, toll-like receptor 4. They taste the lipopolysaccharides, and that will signal the activation of the TBK1, and then TBK1 activate the NFK beta rate, and this will lead to expression. Most of the time when you have lipopolysaccharides here, the macrophage will turn into M17 and will turn on the TH17, and then TH17 will secrete also interleukin-6 and interleukin-17, which will cause the differentiation of the white blood cells into neutrophil, because that's how you kill the bacteria, by neutrophil. But if you see here that how the toll-like receptors in the macrophages is the one who will taste those bacteria, and the macrophage will turn into M17, and then the macrophage will release those interleukin-6 and interleukin-1 and all those cytokines to eventually turn the naive T cells into TH17, and then secrete interleukin-6 to differentiate the white blood cells into neutrophil, and then neutrophil will go ahead and eat those bacteria. Along with this will activation also interleukin-4, so you will have some Th2 active as well to produce antibodies that will lead to neutralizing those bacteria. Because you need neutrophil, you need an antibody to kill, and so you need Th2 and Th17 to really attack and destroy those bacteria. In addition to that, as you see here, when we have those fat cells, or when we have obese patients, and there's too much of fat cells, those fat cells, they are not good because they secrete interleukin-6, and they can lead to inflammation, right? When weight gain is not good, it's not healthy. When you see somebody with big belly, that's not good, because all those fat cells, they tend to secrete interleukin-6. And one of the things that we can use to manage and even to burn those fat is using Amlexonax. And Amlexonax will inhibit the expression of the interleukin-6, through NFKB, and also through inhibition of phosphodiesterase. Eventually, that leads to decrease of those cytokines that's released from those fat cells, and decrease the macrophage from being polarized either to M17 or to M2, and that decrease the Th17 and Th2. Eventually, it will help to suppress the inflammation. And also, Amlexonax, during that, also, it stimulates the lipolysis and it stimulates the beta oxidation. So it helps to decrease weight, right? By shrinking those fat, by dissolving those bubbles of fat that's inside those fat cells. So it does help to stimulate the catabolism of fat, and leads to burning of the fat, and also it leads to increase the mitochondria, so turning those white fat cells into brown fat cells, and that will lead to weight loss. So it's both. It's for metabolic and also for the suppressing the inflammation. So Amlexonax, trade name is Sulfa. It's a tricyclic amine carboxylic acid. Is a potential treatment option that was traditionally used as a treatment for recurrent aphthous ulcers, right? The mouth ulcer, until it's discontinued in the United States. I don't know, it's a stupid thing being done in the United States. In 2017, why? They say because they have options, other options available. Although this drug has many, many other applications. I mean, you can use it to manage all chronic disease across all medical specialties. You can use it for genetic disease. 30% of them is because of the nonsense mutation. And I will have Dr. Mike Beamer to go through more about the pharmacokinetics and pharmacodynamics and about this drug. And I will have him talk about the reason why they stop it. There's no really bad thing that they hear about it. It's more about, well, this is being used for optic ulcer. There's another drug that can be used, and it seems like the big pharma, the other drug, it's more patent, more money, so that drive the whole thing, and they forgot about this very precious molecule that is being missed. And now we learn that we can repurpose this drug, and we can learn from Japanese doctors that can be used for managing a variety of inflammatory diseases, and we want to start making it again here in the United States. Mike Beamer is actively working on making this drug available for us. So in other countries such as Japan, Amlexonax is authorized to treat asthma, allergic rhinitis, and so they also use it for conjunctivitis. So that means they have a form of eye drops. Not just that, I mean, this drug has a potential also to treat fibrotic diseases, right? So because it inhibits TH17, it inhibits interleukin 6, it inhibits also the transforming growth factor beta, the TG, the transforming growth factor beta. That's mean this drug has a potential to treat liver cirrhosis and corneal ulcer. Same like, you remember those losartan eye drop we talked about? Yeah, this Amlexonax has the potential to treat fibrotic diseases. And we know fibrotic disease are one of the pandemic or epidemic diseases, a hidden disease, we call it hidden epidemic disease, that we fail in managing it, right? We fail to manage fibrotic diseases, liver cirrhosis, corneal scar, lung fibrosis, kidney fibrosis, all this is we fail to manage it. We fail to manage adhesions, right? But this drug, along with losartan, do have a potential to manage those fibrotic diseases because they inhibit the transforming growth factor beta, the inflammation, which is TH17, that mediate the fibrosis, and they actually inhibit the fibrotic growth factors directly. And so we have potential using this drug for corneal scar, for glaucoma, because glaucoma is a blockage in the trabeculae, which is then at the angle of the anterior chamber of the eye, right? There's fibrosis there that blocks the drainage, and we can go ahead and open that using Amlexonax. So there's a potential to treat glaucoma, corneal scar, liver lung fibrosis, liver fibrosis, in addition to its ability to transcriptional rethrow genes that's being mutated, called nonsense mutation, and we can kind of manage 30% of genetic diseases, including cystic fibrosis, Duchenne syndrome, and many others. We're going to have it, man. Big another section of Amlexonax related to managing all those nonsense mutated genes, diseases, whether it's genetic or cancer. And as we know, we use it for asthma because it stabilizes the mast cell. So it's a mast cell stabilizer. It does not inhibit the histamine, so you don't have the sedation effect that Benadryl has when you take Amlexonax. It just stabilizes the mast cells, and it inhibits the inflammation. It inhibits the TH2 and TH17, which mediate the inflammation of asthma. So Amlexonax has also been shown to treat and reverse the progression of fatty liver diseases. We know why, right? Because it stimulates the beta oxidation. and it helps to degrade those fats in the liver. And it increased the mitochondrial function, and definitely this helped to break down the fat. And so we can manage not just liver fatty liver diseases, but non-alcoholic fatty liver disease, but also we can use it to manage liver fibrosis itself, because it inhibits the TH17 and transforming growth factor beta and all the growth factors, the fibrotic growth factors. So we can use it also for liver cirrhosis. And we have a study, I think it's conducted by he et al. It seems like a Japanese, which utilized the mouse model and demonstrate improvement in metabolic disturbance, right? Metabolic syndrome, whether it increased insulin sensitivity, it increased lowering the sugar, it activates the beta oxidation of the fat, it stimulates lipolysis, right? And the beta oxidation, so you're burning the fat. And this definitely will lead to decrease in the hepatic ketosis. Okay. And so we can see that Amlexonax inhibit the NFKB. And when you inhibit the NFKB, you decrease all those inflammatory cytokines, and you inhibit the NOx enzyme, and you inhibit the free radicals that will oxidize those receptors of insulin. And actually, it will block the reuptake of sugar. It will not block the signal of insulin that leads to activation of AKT, all those kinase protein, which actually leads to metabolic syndrome, right? Because AKT inhibit the AMPK. There is another path here, it's missing. So, but it will inhibit the glucose uptake. So insulin is not good. Too much of it, it will stimulate the AKT, which will block the AMPK. And blocking the AMPK will lead to insensitivity of glucose, or insulin insensitivity, we call them, and then you end up with hyperglycemia and metabolic syndrome. And so inhibiting the whole process and inhibiting the AKT and inhibiting, and that will lead to stimulation of AMPK, because if you inhibit the AKT, you stimulate the AMPK, and then the AMPK will increase the mitochondrial biogenesis, activity of the mitochondria. It will increase the glucose insulin sensitivity and the glucose reuptake, and decrease the glucose level in the blood. And also it stimulates the lipolysis and the beta oxidation, and that leads to management of the non-alcoholic fatty liver, and also it leads to managing liver cirrhosis. And this is very important, is that the Amlexonax activate the AMPK by inhibiting NFK beta, but also Amlexonax directly can activate and stimulate the AMPK. We know the AMPK is activated by polyphenols as well, curcumin, ECGC, quercetin, all those stimulate the AMPK. So that is the beauty of Amlexonax. It decreases the inflammation and it manages the metabolic syndrome. Steroids cannot do that. Steroids, yes, it will help the inflammation, but it will lead to metabolic syndrome by inhibiting the AMPK. And when you inhibit the AMPK, you lead to oxidative stress and you lead to inflammation. That's why you end up with atrophy, and the patient gets sick from the steroids, and then you end up with this abnormal fat redistribution and atrophy and all the bad stuff because of the oxidative stress that's being generated from the long-term use of cortisone. So short-term is good, long-term is not good to use cortisone because it leads to metabolic syndromes, diabetic, hypertension. We know that side effects, common side effects. But we know just it leads to this, but we don't know exactly how. Why steroids leads to secondary hypertension and diabetes? The reason, because it blocks the AMPK. And you can see here very clearly that how Amlexonax will manage the fatty liver, right? And it's doing that by inhibiting the NFK beta, as you see it here. And it definitely doing that, it will stimulate the AMPK. And when you stimulate the AMPK, you inhibit the mTOR and you stimulate the autophagy, and also so you get rid from inflammasome and senescent cells. but you manage the whole fatty liver by stimulation the lipolysis and by stimulation of beta oxidation, right? Mitochondrial beta oxidation. And doing that, this will help to manage any oxidative stress. And doing that, this leads to decrease the inflammation, as we learn here, and it will increase the insulin sensitivity by inhibiting the NFKB. Okay, so metabolic syndrome is due to inhibition of AMPK, and Amlexonax activate the AMPK. And we know when you inhibit the AMPK, what will happen in the liver? You will end up, it will increase the lipogenesis if you inhibit the AMPK, which is the leads to metabolic syndrome. You will block the beta oxidation. You will cause inhibition of the mitochondrial function. You will lead to oxidative stress, and you will lead to accumulation of fat in the liver, and that leads to non-alcoholic fatty liver. So what we need to do, we need to activate the AMPK, and that's what Amlexonax does. It will activate the AMPK. When you activate the AMPK, you increase the mitochondrial function, you increase the beta oxidation of the fat, you increase the lipolysis, and you increase the beta oxidation, which means you're burning all the fat from the liver. And definitely by doing that, you manage what we call the liver, fatty liver. Plus, by inhibiting the TH17 and transforming growth factor beta, you can also manage the liver cirrhosis. Again, this shows you Amlexonax as well. It one of the drugs that used to manage fatty liver, but there's other drugs that do the same thing, and they help to stimulate basically the AMPK eventually. Okay. So Amlexonax is a stable compound as a powder stored at 20. So you store it at -20 if you want to have a shelf life of 3 years. As a clinician, of course, or you can. This is if we want to keep it for 3 years, but for regular use, you don't need to store it 0.20 Celsius degree. It has a similar chemical structure to sodium chromoglycate, because in the beginning, when they created this drug, they created as a mast cell stabilizer, right? Like a sodium chromoglycate. That's our mast cell stabilizer. And its topical use has been widely accepted, and they've been using it for aphthous ulcer, and its effect attributed to its anti-inflammatory quality. At that time, they don't know really how it works, but now we know in detail how it works. And the successful use of the treatment with favorable safety profile. So that's the beauty here. It's the safety profile, very important. Safety, safety, safety. In atopic disease as an oral agent has been established and is currently approved for treatment of asthma in Japan. Why it's not here in the United States? Well, because there's no money behind it, possibly. But if there's a way to generate money, they will bring it here. So that's where the compounding pharmacy, they can take this drug and repurpose it, and it's legal for them because it's already an FDA approved drug. The efficacy and safety profile of Amlexonax was previously evaluated by a number of studies, and they did the 6-month toxicology study using dog, determined that the dosage of oral Amlexonax at which no side effects demonstrated is 10 milligram per kg per day. And then it was later determined that the dosage of Amlexonax paste for ulcer will be approximately 12 milligram per day for Amlexonax. Furthermore, it was demonstrated that when Amlexonax is administered to rats at dosage of 300 milligram per kg per day, there are no carcinogenic effect and had no significant effect on reproductive activities on the rats. I think they have also human studies, because if they are using it for humans in Japan, that means they're already past the safety profile for a long time. And I think the dosage that we recommend is 40 milligram 3 times a day, the max, I think. The main contraindication for administration of Amlexonax is any known hypersensitivity. So you may have allergic reaction to Amlexonax, like any other drugs. Any drugs, we have the potential of having allergy, and there's some case reported of allergy. from either from Amlexonax or from the ingredient that's being added to it. When those ingredients, we call them inert ingredients or not the active ones. And a case report of 23-year female who treated for allergic rhinitis with oral sulfa 25 milligrams described a rapid skin rash during the treatment. So what they did, the positive patch test based on a suspected allergic localized skin lesion confirmed. So she has an allergic reaction to it. You can discontinue this, or you can use it in a form of topical, possibly, that may override the allergy. Based on double-blinded randomized placebo-controlled study, 42 objective subjects, there were no serious significant adverse events. That's a good thing. To 3 times daily oral Amlexonax, we use almost 40 milligrams. In the study, 2 patients who experienced perivascular inflammatory rash due to reaction to it improved with local treatment. So if they have oral allergy to it, you can use it with local treatment, and both had favorable response to the drug. Okay, so either you discontinue it or you can change it topical and it works. So, given the recent data that demonstrate the potential of Amlexonax to bind and inhibit the tank binding kinase, which is a kinase protein, as eventually they inhibit the NFK beta, and as a treatment to further explore to reduce inflammation, right? And we can use it for many applications that's inflammatory in a wide range of conditions. That's why I said you can use it for almost any chronic inflammation out there, because it does inhibit the Th1, Th2, Th17, right? So if you have rheumatoid arthritis, you can use it for. If you have allergy for Th2, Th17, you can use it. Psoriasis, ulcerative colitis, Crohn's disease, all of this can be used. Any kind of inflammation, even also the neurodegenerative disease as well. And the beauty of it, it also is not just inflammatory diseases, but also metabolic. And that's the unique about this drug, right? Including fatty liver and liver cirrhosis. And this is very important slide. Here's the AMPK. See, this is the important molecule or enzyme that we need to know. This protein. This is a kinase protein, and it's activated by what? By fasting. When you have fasting, what would happen? You would have a lot of AMPK, right? Because ATP will turn into AMPK. It's being used, those batteries. And those used batteries, which is the AMPK, right? That's being discharged because you remove those 2 P's, right? Those empty batteries, they are the one who will activate the AMPK. And why they activate the AMPK? So the AMPK will activate the mitochondria to generate energy, right? And activating the mitochondria in cancer can lead to mitophagy and kill that cancer. Or activation of mitochondria and increasing the biogenesis of mitochondria will help in burning fat, right? Turning those white fat into brown fat. All right. And it's very important to activate the mitochondria to kill the cancer and inflammasome and senescent cells. So it's involved in autophagy. But again, AMPK doesn't inhibit the mTOR. And if you inhibit the mTOR, you stimulate autophagy, because mTOR is mediating the stimulation of the apoptosis. And as I said, when you activate the AMPK, what you have lipolysis and beta oxidation. That's what we need, right? To burn fat. Break down the fat and burn it. Okay, slice it and burn it. Put it in the oven, which is the mitochondria. And the mitochondria is being active, ready to go. What else? It increases the insulin sensitivity, which means the glucose uptake, and the glycolysis. And it decreases the gluconeogenesis and the glycogenesis. And that's what we need, right? Okay. So what would happen? You would have a lot of ATPs generated because of this. And because you're burning the fat, you'd be sparing the sugar from energy, right? And this would help in managing metabolic syndrome. Metabolic syndrome, it includes obesity, hypertension, hypertension mediated by atherosclerosis, right? Hyperlipidemia, atherosclerosis, and diabetes. So there is evidence of its role as an anti-inflammatory mediator and antihistamine. We talked about that the drug initially it was a mast cell, or it was a mast cell stabilizer. And we talked about inhibition of NF-κB means inhibition of all the inflammatory cytokines and the free pathological free radicals. So it does help to put the inflammation down. So it has anti-inflammatory effect. Among its stellar effect, the drug is inhibitor of NF-κB and the TBK1, which are kinase protein. And we know when you inhibit the TBK1 and you inhibit the NF-κB, you inhibit the expression of the inflammatory cytokines. You inhibit the free radical generation. You put the fire down. The macrophage cannot polarize and mature and become M1 or M2 or M17, which will lead to stimulation of the native cells to TH1 or TH2 or TH17, right? So it suppresses the whole inflammation across the aisle. And also, when you do that, you suppressing also the interleukin 1, which also suppressing natural killer cells as well, activation. So it does help to suppress the innate immune response. And the beauty of this Amlexonax, it also inhibits the fibroblast growth factors, which means I can use this drug to manage all kinds of fibrotic diseases. I can use it for corneal scar, for glaucoma, for the cirrhosis, for lung fibrosis, for kidney fibrosis, for scar, for adhesions, for aging, because aging is fibrotic disease. When we grow and age, the fibrosis will increase and make us look cranky and aging, and our skin wrinkled, right? No elastic fibers because of too much of the collagens and the fibrosis. And so I think it has an anti-aging effect as well, because it doesn't have the mTOR, and it stimulates the autophagy of inflammasome and senescent cells. So see how much the Amlexonax clinical application, you can see it. You can use it for arthritis, neuroinflammation, neurodegeneration. You can use it for dental diseases, inflammatory dental disease. You can use it for cancer. We know why. Cancer, two ways. One way is we know the cancer do have inflammation, but bad inflammation. The inflammation that does not kill the cancer. So they have the inflammation of TH17 and TH2. They don't, and the TH1 inflammation is being suppressed by the cancer themselves. They secrete chemicals that have the TH1 and cytotoxic T cells. And they are stimulating the differentiation of the macrophage to M17 and native cells to TH17 and TH2. So what you would do with the neutrophils cannot kill the cancer. You need cytotoxic T cells. You need TH1. So the cancer secrete chemicals to move the immune system into TH17 and TH2 and even Treg. And this will lead to the cancer to flourish and grow, because in order to kill it, you need the TH1. And Amlexonax helps to suppress that, helps to suppress the TH2 and TH17, which is a good thing. And then you need to add some other drugs with it to move the thing into TH1. You can add interferon gamma or thymosin alpha, right, along with Amlexonax, so you can move the immune system into TH1 and cytotoxic T cells. But just resetting the inflammation down and suppressing the TH2 and TH17 is part of the management of the cancer. So it helps to manage the tumor microenvironment and suppress the inflammation that promote cancer, which is TH17 and TH2, and also Treg. What are the things they do? In addition to that, we know the cancers, some of them are caused by mutation. It's called nonsense mutation. And those mutations can be reversed by inhibition of NMD, which leads to expression of those proteins that's being mutated. And this may help to stop the cancer from or stop those cells from turning into cancer. So it helps in prevention and managing cancer. Amlexonax, because it helps in metabolic syndrome, it lowers the lipids because it burns the lipid, right? Beta oxidation and mitochondrial lipolysis, we talked about it. And also, Amlexonax has anti-fibrosis because those atheroma, it's not just plaques of fat, but also fibrosis. And so Amlexonax has anti-fibrotic effect and anti-metabolic effect, so definitely will help to manage atherosclerosis, and it's a good thing to manage the root cause of the hypertension, which is atherosclerosis, which is fibrosis and fat flakes and inflammation. But mainly the narrowing is caused by fibrosis. So just by its anti-fibrotic effect would definitely work for managing atherosclerosis. And that's the reason I do recommend giving also losartan, because it does have anti-fibrotic to manage the underlying cause or root cause of the hypertension. Again, we know it's managing diabetes, and we understand why, right? Because it stimulates the AMPK. And because it inhibits the NFKB and decrease the free radicals and decrease the activity of the macrophages, but not just macrophages, but also the osteoclast. Osteoclast is basically macrophage, right? And eats the bone. And by suppressing the inflammatory cytokines and the free radicals, those osteoclasts will be inhibited, and this will lead to use it to manage osteoporosis. Okay. And because of its effect, and as I said, in turning those nonsense mutation back to normal, so we can use it for neurodegenerative diseases, but just because of its anti-inflammatory effect. And it's managing the metabolic syndrome, it's good for neurodegenerative disease as well. You know, neurodegenerative disease, it's caused by oxidative stress, part of it. And if you're able to modulate that and you're able to express those mutated genes that may be the root cause of this neurodegenerative diseases, both ways, then you can manage a lot of them, like Alzheimer, Parkinson's disease. And we're going to talk about it again in another session of Amlexonax. And we know that because it's managing metabolic syndrome, and also it has antifibrotic effect, so it's good to manage and reverse the atherosclerosis, whether it's from the fibrosis or from the fat flakes or whatever. It helps to reverse it, right? Because it's antifibrotic, and also it manages the metabolic syndrome. So we can definitely use it for treating cardiovascular. Not just that, because of its antifibrotic effect, you can also use it for a lot of cardiac problems. You know, when we have those cardiomyopathies caused by fibrosis, and it's because it's reversing it, it definitely helped to regain the function of the heart. So a novel study conducted in 2019 demonstrated Amlexonax, when administered both intranasal and oral, significantly decreased the immune cell response and the cell recruitment in the lung. We know why, right? We already spoke about it, right? NFKB suppress it, you suppress cytokines, the free radicals, you decrease inflammation. Why this study in the mouse, and also don't forget, it does inhibit the LOX and NOX, same like cortisol. Maybe it's not as potent as steroids, but still it dumped those enzymes. NOX and LOX and COX, right? Why the study is the mouse model, there was significant reduction marker of allergic inflammation and cellular mechanism identified, which identified as a therapeutic target in the asthma, right? And we know asthma is just Th2 and Th17 hyperinflammation, and in addition to mast cell activation. So if you can suppress that, definitely you can manage the asthma. So it decreased allergic response by inhibiting the histamine release from mast cells, so it's a mast cell stabilizer. And it was absorbed by inhibiting the cyclic AMP phosphodiesterase. Remember when I talked about that? Just by inhibiting that, it helps to stabilize those mast cells and the release of mast cells. Another study demonstrated that Amlexonax also hold a double function in patient cell line that have nonsense mutation. This is what we talked about, right? And this we're going to cover it in a very detail when we talk about the next part of Amlexonax clinical application. And so the Amlexonax has been found to not only increase the nonsense containing messenger RNA, but also lead to synthesis of the full length functional protein, which those prevent nonsense mediated messenger RNA decay. So we talked about that. We said that those nonsense mutated genes, they have this stop codon. And we talked about those stop codons. There are 3 of them. You are gone, UAG, you are away, UAA, and you go away, UGA. Those are stop codons. And they, because of the mutation, they end up in the middle of those DNA for that specific genes. And what happened? You end up with messenger RNA with the stop codons. Then this enzyme, which is called the nonsense mediated messenger RNA decay, they will find those messenger RNA with the stop codons. They read them out. There's messenger RNA with stop codon. Let's go ahead and destroy it. And they destroy it. This NMD will be inhibited by Amlexonax, which will lead to this messenger RNA to pass that and override the NMD. And then what would happen? The ribosomes will take this RNA and they start reading it, translating it into amino acids into the protein, right? And they will find the stop codon, yes. But here's the thing. Amlexonax will cause the ribosome to bite, to override it, and just insert any amino acid in that stop codon. And so you end up with that protein. Because that stop codon does not have amino acid that's critical for the function of that protein. So they will put any amino acid there and just move on. And so that it helps to what we call the rethrow. That's what we call transcriptional translational rethrow. Not just blocking the NMD, but also it fools the ribosomes or causes the ribosomes to override the stopping, because when they read the stop codon, they're supposed to stop. The protein will stop, and you have the corrupted proteins. Well, or short pieces of proteins. Well, and then Amlexonax will say to the ribosomes when they attach to it, they make it to continue read that and just insert any amino acid there.
Hey, Dr. Halassa, quick question.
Yes. Go ahead.
So, okay, because I think I'm understanding it better. So yeah, we've got stop codons. These codons prevent the transcription of the messenger RNA. We have this nonsense mediated messenger RNA decay enzyme, I guess that's what it is, that prevents the RNA, the protein, from being translated or produced. And but then so Amlexonax through one of these pathways, I think it's still connected to the phosphodiesterase sort of lineage pathway, decreases the NMD, the nonsense mediated messenger RNA decay, and then it upregulates what is actually putting in something, replacing the stop codon with just an amino acid that is harmless or that will not stop the transcription. What is?
Will not stop the translation. So after you block the NMD, so the MD is not going to destroy those messenger RNA that has the stop codon, right? But then the ribosome will go and read them. And when they read them, they see the stop codon, they stop stopping the translation.
Okay.
Because there is no equivalent to those stop codons. There's no amino acid that will be equivalent to those stop codons. You got my point? And so they will just put any amino acid there and override that stop codon. And what stimulates that is the Amlexonax. So that's 2 ways. It works on NMD, inhibit that, and also works on the ribosomes and override it. It's called the rethrow, transcriptional translational rethrow. So the ribosome can rethrow it and just put any amino acid there, because those are positions where it's being mutated is not important in the function of that protein.
Okay, so it's upregulating the ribosome's ability to read through the transcription and
Translation of the, yes, the
the
translation.
translation, despite the stop codon. It
Right.
allows it to read it and ignore the stop codon.
Exactly.
And this is good because the stop codon is not, it's nothing that is really affecting the protein. It's a nonsense.
Yes, it's a nonsense. Well, it does not have the amino acid that's critical for the function of the protein. So you can put any
Okay.
amino acid there and move on. Yes.
Okay.
It makes sense.
And it's putting on any amino acid.
Any
or
amino
it's just,
acid, just go ahead, put it there, and just move on.
oh, okay.
But
Or
the
match.
ribosomes, well, not, you know, they just let's get this protein going. Let's get the to manage cystic fibrosis.
When it's copying, it's just putting, okay, it's the stop codon is when it's copying, it's just putting any amino acid in its
put any amino
place.
acid. What does that is Amlexonax, certain way to turn the ribosome and make it to override it. And they will just continue translate the whole thing. Okay. And in other words, Amlexonax is like grabbing the ribosomes to break the law. And move on. That's kind of bribing, right?
Hey, Dr. Halassa.
Right.
Hey, here's a question. How does this, now let's consider how that relates to the spike protein. If we're going to, how the spike protein in the vaccines is causing problems because it has issues with stop codons.
Up to now, I don't have any studies where the spike protein involved in mutating genes and causing but we know that the spike protein does induce inflammation.
Well, we know the mRNA. Think about this: the pieces of mRNA that are in the vaccine, they have a different stop codon on each end of it that's been removed. Right? Is that my understanding?
I don't have that details about.
Okay, we can talk about that.
We can talk about it. Yeah, and I need you to prepare a lecture for Amlexonax, pharmacokinetic, pharmacodynamics, and everything related to the pharmacy. The same we did with McCarran Blvd.
That's no problem. That'll be actually, you covered a lot of it. But what I wondered is if we would, I just want to make sure that if we start to use this drug, we aren't going to trigger spike protein related reactions from the mRNA.
What we can, for confident, we can say that Amlexonax, because it's a mast cell stabilizer, and we know the spike protein is a mast cell activation syndrome because they activate the mast cells, and that leads to whole inflammation and the post-COVID-19 symptoms. It's the mast cell activation syndrome, basically, and that leads to mast cells to release not just interleukin-4 but also interleukin-6. And mast cells, when it's overactive, it can lead to all this coagulation and increase the D-dimers and the clotting and all that stuff. But in addition, the spike protein also activates the platelets directly. So we know
it seems like it's a drug that could be used in that case.
So so Amlexonax, because it inhibits the Th17 and because it stabilizes the mast cells, it can work like Benadryl. Still, it will be good if they have the acute condition of the post-COVID and you have all the symptoms. You need the histamine blocker. And then you continue with Amlexonax. So we cannot really say, hey, we can use Amlexonax in acute condition of post-COVID, because those patients, they have headache and they have nausea and they have rash. We really still need the histamine blocker. So you add Benadryl. But to stabilize the mast cells, which is very important because the spike protein do activate those mast cells, then we can use Amlexonax. But Amlexonax, because it suppresses the whole inflammation, so it's good for post-COVID. So I think I would add it as part of the post-COVID.
We can think about that a little bit. Here's another question for you: not a question, but a point. I've worked a lot in dermatology, and atopic dermatitis is a common condition. And it's really mysterious. And when you talk to dermatologists, they don't really seem to have a clear understanding of it. But they just know how to treat it, and they know what it is and how to diagnose it and all of that. And how to treat it. But it's really, I just looked it up, it's a Th2 immune polarization. So when you see the word atopic or atopia, it specifically refers to a Th2 polarization of CD4 cells and an overproduction of IgE.
Yes. And Amlexonax will help it.
Right. If we're talking about that that the canker sores, the original FDA approval for this drug, was for quote unquote atopia, which was not really well defined at that time. And now it's well defined as a CD4 Th2 immune polarization and causing a hypersensitivity and overproduction of IgE. So that creates the the hyperallergic response. But you've really defined what that is here, and I never really could clearly understand.
Let me add something to it, okay? There's not just Th2. There is also some components of Th17.
Yeah. Yes.
Okay? So it's Th17, Th2, and sometimes they end up with a hybrid. And yes, you see the dominant is Th2 if there's itching. If there is no itching, it's dominant Th17. So that's the, but they are really two, both Th2. So the asthma is both. It's Th2 and Th17. COVID is Th2 and Th17, COVID-19.
Yeah.
Condition. So we need to consider also Th17. Amlexonax inhibit, regardless of what it is. They inhibit the whole, whether it's Th2, Th17, mast stabilizer. This molecule, I never hear, I mean, we don't have such, even a McCarran Blvd does not do what Amlexonax does. And I would like to thank Dr. Joseph James to bring this molecule on the table for chronic disease prevention management, because right now I consider it as the top drug. And add to that, it will use to be treating 30% of genetic diseases, which we think all those red flags, genetic disease, nobody can touch it. We can work on damping the inflammation and might do all those things, but expressing mutated proteins, this is a phenomena that we can do a lot with patients now with more confidence. The question is that, is you doctors here, how many doctors? 25 doctors. Would you be starting prescribing it and then come back to us and say, we find difference? Because that's more important than saying it works and we have all the studies. But I mean, we still need to use it clinically, and we need it for the doctors here to confirm and validate that. We did it with McCarran Blvd with success. And yes, we got everybody happy with it.
Well, the drug is safe, Dr. Halassa. You know what might help is, could you describe for us a typical patient or a condition where this might be useful?
I mean, it's endless. You can use it for neurodegenerative disease, Parkinson, Alzheimer. You can use it for multiple sclerosis. You can use it for Crohn's disease, ulcerative colitis. You can use it for psoriasis and allergy and asthma. It's blocking. I mean, it suppress or modulate the immune system across the board. We don't have any molecule can do that. I mean, there's only few drugs out there. They block the NFKB. Most of them, they block the downstream of it, not the NFKB itself. And then as a mass selective a stabilizer, and then as a nonsense mediated messenger RNA decay inhibitor, that's a big thing. I can use it for 30% of genetic disease, including cystic fibrosis, Duchenne syndrome. There's many other. I'm gonna list those genetic diseases and cancers, and the next presentation, I will list all those diseases they have studies for it. I don't have it in my mind right now, but I'm preparing for it. So the next lecture, I will put all the list of the diseases that have studies. But I'm just saying in general, with the mechanism of action, we can use this drug in almost any inflammatory and metabolic diseases. There is no anti-inflammatory drug that is also helping metabolic. Yeah, you can say curcumin does have anti-inflammatory and some metabolic, and berberine does the same thing, but not as effective as Amlexonax.
I do want to speak from experience because I have taken it, but that's what attracted me about it when I started looking at all the different studies related to tank binding kinase and started understanding the mechanisms better, is that I took it because of the post-COVID fatigue-like symptoms, say brain fog, neuroinflammation, headaches, especially allergies, especially during the springtime this year, and sort of battling metabolic syndrome. like if I'm not, obviously I'm more active than I was, I'm improving, but these things seem to, basically I had all of the things that these mechanisms were modulated by Amlexonax. So that was why I used it. The allergies cleared up beautifully. I had times where the brain fog was disappeared, and just knowing that metabolism was improved, and also I was going to say the with a lot of the myalgias that I've had over the past 3 years, I had a lot of muscle tightness, and like you said, there's an epidemic of fibrosis. Well, we know that when you have mast cell activation syndrome and maybe difficulty clearing the COVID virus, all of these things, you're getting increased expression of TGF beta, which is triggering more fibrosis. You're having the interleukin, for myself on my lymphocyte map, I had Th17, Th1 dominance, very characteristic of neuroinflammation. And I think I actually did have some fatty liver. So it just seemed like it was handling all of everything. And that's what really attracted me to it and kept me digging in deeper to say, hey, I think we need to take a look at this. But I do have one thing, and I do want to mention, because you brought up the stop codons, which is just takes it to the next level, is that now when I come across cases, and I get a lot of crazy cases, I have a 49-year-old female, otherwise healthy, had one natural birth at the age of 40, who has had issues with nausea and vomiting. I would say more on average than your average person. And it's like during her pregnancy and probably before pregnancy, she's always had issues with a weak stomach. And she finally got some testing done, and a liver ultrasound and an MRI says that she has a focal nodular hyperplasia versus hepatic adenomas. And here's the thing, here's what I'm getting at, is that as I'm combing through the literature, translating the literature, suddenly I hear that there is a genetic predisposition. Why is she having these focal nodular hyperplasias of pretty big size in her liver? Well, it does seem to be a genetic predisposition, and they mentioned that it having a stop codon. Okay, so suddenly it opens up a whole nother door of, wait a minute, we might be able to do something about this. And that's the other thing that really energizes me about this molecule, is that, we might be able to actually do something. Whereas, you know that she's being told by her primary regular doctors that, oh yeah, we'll just watch it, we'll get an MRI, it may or may not turn into cancer, probably not, we don't know. Well, we may be able to actually do something. So that's my point.
Well, great. I mean, I can see that with can you hear me? Okay, go ahead, Patel.
Okay, I have a question.
You have two devices. You need to close one of them because you have the sound. The echo. Are you there?
Yeah.
Okay, you close one of the system, one of the device. Your phone or your whatever. Yeah, you still have that.
You go ahead.
You need to close one of your devices.
Yeah.
Or turn your volume down.
Yeah.
It's the Jimi Hendrix.
Okay. Are you there, Dr. Patel?
Yeah, I'm okay.
Okay, so once you fix it, then I'll give you the, so Amlexonax is currently produced in either 25 to 50 milligram. I think Mike Beamer has it in 40 milligram. And we know it's good for asthma. We talked about it, why, and allergic rhinitis. And the drug treatment is based on inhibition release of histamine. So that's where they started. It's a mast cell activator, mast cell stabilizer, sorry. And it also inhibits the inflammatory leukotrienes by the mast cells and neutrophils. So it does inhibit the NFKB. So that's mean it inhibits all the cytokines, whether it's Th2 or Th17. And so it's used for allergic rhinitis. I think it's more than that. You can use it for any inflammation, not just for Th2, Th17, but also for Th1, Th17, like rheumatoid arthritis and systemic lupus and sclerosis, and also colitis, Crohn's disease. And the study, there is still there you go. In human study conducted by Kawa, I think is a Japanese, because those names are difficult to pronounce, demonstrate that Amlexonax acts as a bronchodilator for patients with aspirin-induced asthma. So that's a new thing. Whether it's directly bronchodilator, like the dilator, you know, they activate the B, or it's working through the inflammation. But it seems like, I mean, for aspirin-induced, how the aspirin-induced bronchoconstriction? Do you know how? Anybody can remember the mechanism? Dr. Patel.
From prostaglandins. Well, I'm sorry.
Exactly, the prostaglandins.
Yes.
And, it seems like Amlexonax maybe will reverse that. And it has similar chemical structure to sodium chromoglycate, so it's a mast cell activation stabilizer, which is known as a bronchodilator used to treat asthmatic patients. So it seems like maybe directly it dilates the bronchus, or it reverses whatever prostaglandins that's being inhibited by the aspirin. In this study, 15 patients, 7 non-aspirin induced and 8 aspirin induced asthmatic were studied, and spirometry was performed at regular time interval, just to show the efficacy of this drug to reverse the asthmatic induced by aspirin. But just because it decreases inflammation and because it's a mast cell stabilizer, that will justify it to be managing asthma in general, regardless whether it's aspirin induced or pollen induced or environmental induced. I will just give it to all the patients with asthma.
I did forget to mention that.
Yes, go ahead.
Yeah, I did forget to mention that the other reason why I was attracted to it is that I was looking for a mast cell stabilizer that didn't make me tired. Okay, so I do take Benadryl at nighttime, but during the daytime, I wanted something that actually worked that didn't make me tired. And so that was the other thing. There's no sedation whatsoever with this.
But I don't think it has direct histamine 1 receptor blocker. It's more of stabilizing the mast cells. So you still need, if you have too much of histamine out there activating the histamine receptors, you still need to have either Benadryl or other drugs that is an old antihistamines like hydroxyzine. Hydroxyzine, it could be an equivalent to Benadryl. And that blocks the histamine, especially the H1. I like patient with mast cell activation syndrome, they have insomnia because histamine involved in activation, the reticular formation of the insomnia, and it keeps your brain active. So you really need to block it. And then you can use this to stabilize and as a maintenance treatment and Amlexonax. So it will be a good but still, as what Dr. Patel is doing, and she's recommending all the plastic, no aluminum, all those chemicals that you can get rid from your kitchen. And the reason, because all those petrochemicals that we've been exposed they are mast cell activators. And when you activate your mast cells and you push your immune system to Th2 and also Th17, you compromise the immune system to kill the cancers, and you increase the risk of having cancer. So it's very important to work on your histamine diets, any histamine-induced diets or poison or toxins, environmental, including fungus infection. Those fungus, what they do, they also polarize the immune system to Th17 and Th2 and activate the mast cells, and they put you at risk of having cancer. So allergies needs to be managed. Don't think, oh, I have allergies, okay. So no, allergies, people with allergy, they have high risk of having cancer because you're exhausting your immune system to polarize it to Th2 instead of Th1. And so all of these things needs to be neutralized and optimized. So you as integrative doctors, mainstream medicine, asthma, what's asthma, what allergy, what mast cell activation, they don't even see it and they don't even diagnose it. It's a hidden epidemic. But you as integrative doctor, like Dr. Patel is one of those doctors who are that have the insight that health optimization include balancing the immune system, and it's part of the pillar of the chronic disease prevention management. So we need to tell the doctors that you need to balance your immune system to minimize the risk of having cancer. And so the 4 pillars of chronic disease prevention management is 4 things: redox, immune, metabolic, and then restoring the regenerative status of the patients using stem cells. But just by doing those 3, you end up helping to restore the regenerative status. Go ahead, Dr. Patel.
Okay.
You still have the echo. You still have 2 devices. So according to 2017 Japan guidelines for adult asthma, Amlexonax is currently defined as relief agent, rescue agent, mainly treating asthma exacerbation due to its histamine inhibiting properties. It's often prescribed in addition to controller agents, which are prescribed to control the long term of asthma. And it is a mediator anti-releaser, so it's a mast cell stabilizer. And the clinical effect of this drug is improving the asthmatic control, extend beyond its antihistamine properties because it also inhibits the Th17 and Th2. So it has an anti-inflammatory part. The TBK1 has also been noted to phosphorylate insulin receptor and in the study, and definitely this will lead to what? Lead to insulin resistance and metabolic syndrome. And so very important to block this TBK1 in order to improve the insulin sensitivity and manage metabolic syndrome. And doing that, you can also manage the obesity, right? Because you increase the mitochondrial function, you increase the beta oxidation, the lipolysis, you increase the insulin sensitivity. So the AMPK activation is very important, which is inhibited by the TBK1. And Amlexonax inhibit the TBK1, which leads to activation of AMPK. And so AMPK is a very important kinase enzyme. And I need to have a lecture, maybe Dr. Joseph or Dr. Patel will come up with a complete lecture on AMPK, because AMPK activation mediate the mechanism of fasting, mediate the mechanism of exercise, because exercise increases the physiological free radicals, and the physiological free radicals activates the AMPK. And
I have one question for Dr. Joseph.
Go ahead.
Said that he used the Amlexonax, and then what effect did it have on his brain cognition? What happened to his recent memory? Did he have a problem with the recent memory? And if it is so, then was it better? Because this is a very common problem with the post-COVID patient. And if it works on the inflammation and everything what you have mentioned in all different mechanisms, recent memory recall has been a big problem in post-COVID patients. So I want to find out from Dr. Joseph that he said he had a brain fog, and did he improve with that? And if he did improve, then what kind of problem he had with the recent memory recall and how much it improved, how long did it take, etc.?
Well, I mean, all I can say is I've been taking it now for about 2 months, maybe a month and a half. So I did have feedback that my speech is a lot more fluent. Okay, so most of the time that I've been talking on these Zoom calls, especially going back when I listened to some of them, I could see clearly that I had a lot of word recall problems. And just recently, I've been told that, wow, I sound like I'm talking a lot more fluently. I'm talking faster. I'm not stopping or slipping over my words. That's been a big problem for me over the past few years. But what I can't say is that other things are not contributing to it, because I am trying out some antifungal products. I do have evidence of mold toxicity in one of the Array 12 lab tests, which is associated with Cyrix Labs. And I do have like symptoms that would be connected to, or that would point towards mold toxicity and possible fungal overgrowth. So I've been
memory lapses.
Memory lapses. What do you mean specifically?
Like, what did you do today? And then it just takes you a while before you answer, or you just say that, no, I don't recall. And then you later on, you remember, oh yeah, this was the question and this was my answer. But you were not able to say when you were asked or when you were put on the task at the time.
Yeah, that's pretty common. Like things I would normally remember, somebody asks, it just can't seem to remember. And these are not, necessarily difficult things. It's like I'm like even people and people's names, and I'm like, gosh, what is his name? And that happens a lot. As far as my mental state, when the brain fog is bad, okay. It feels like everything is in slow motion. And I cannot seem to focus or direct myself to get things done efficiently. And everything seems very like difficult. Like simple things seem difficult, and learning new things, incorporating new things seems difficult. If somebody were to say, oh, you just got to get that app on your phone and then you can get your answer there. For me, it's like, oh my goodness, now I've got to get the app. I've got to sign up. They probably want to answer some questions and I'm probably going to mess it up. And I don't want to do it because it sounds exhausting. Well, that's ridiculous, because the reality is that shouldn't be complicated. That shouldn't be difficult. Even if maybe if there's a few things, technical things that you have to figure out. But for me, it just seemed exhausting, absolutely exhausting. A couple of times when I did use Amlexonax, especially the first time, I was having one of those really bad brain fog days that it just seemed like nothing would work. And I took the Amlexonax, and it took about 2 to 3 hours. And all of a sudden, I felt normal. Okay. So, I take these things as little evidences to take along with me, and look for these times when it appears a small miracle happens, right?
So let me ask you one more question, that all other problems you had, like you said, you had a mold problem, mycotoxin problem, etc. But was that the COVID was the last one that broke the camel's back?
That's what I think, because when I got my first lymphocyte map in 2022, I believe, I think that's when I got it, either at the end of 2021 or at the beginning of 2022. I had evidence, and I could show it to you. My total lymphocyte count was about 1,000, and the normal is, at least according to the Cyrix lab, is 1,200 to about 3,600. My CD4 count, I'd have to go back and look, was close to about 300.
Wow.
300.
Oh,
That's
that's
as far
worse
as I
than
know,
HIV
that's
patient.
that's AIDS, right? Or
Yeah.
that's right.
Yeah, HIV,
So
when you say that it's less than 500, they're in trouble.
exactly. That's why, and when I try to explain to people, like, look, I'm sick. It doesn't really register because I might look okay, because I've got all the different peptides and different
Yeah.
things that I'm doing. But it's like, that's what broke the straw's back. It's like all of a sudden, it's like, yeah, what happens to AIDS patients? They start getting opportunistic infections,
Yeah.
right? And so suddenly my symptoms turned into the symptoms that seem to be involved with mold toxicity, because they seem identical to me. A lot of the mold toxicity symptoms and post-COVID fatigue, they overlap. In fact, I'm beginning to wonder if post-COVID fatigue has more to do with fungal overgrowth and mold toxicity for people for which their symptoms are going on longer than a year.
No, but
And
I think that you have to pay more attention to your mitochondrial function. And there is a special mitochondrial cocktail. And if you start taking that along with the mitochondrial peptide and try to do that, and at the same time, you are taking, because this is what is going to help you with the mitochondria, and like Dr. Halasa pointed out, that if you do the AMPK and you put that up, that would be good. So I think that what you are saying, that you took the Amlexonax and then you started feeling better, how many blockage you removed and how many blocks or the inflammatory cycle you put in NF-kappa B and TH17, IL-6, IL-4, whatever you blocked, and that would have effect. Well, I still think that nobody has talked about endothelial dysfunction and vasculitis, and that is the part of this process. And I think that we should talk about these to address the endothelial dysfunction, because if we talk about that, because yes, clotting is secondary, fibrin monomer is secondary, but vasculitis, and that vasculitis we have to address. And as an antioxidant, I think the vitamin C and other molecules do play a great role. We have seen patients with the anaphylactic shock after the COVID vaccine, which works similarly. Food sensitivity develops, chemical sensitivity develops, and we cannot explain everything on the basis of the mast cell activation. And because yes, that would be the histamine. And if you take care of but histamine didn't work on her. The prednisone super high dose worked for a while, but then she developed osteoporosis from that before she came to me. So I think we are all going on the right track, but there are some more points that we need to address. And always remember, mast cell activation is a piece of pie, and it is not the whole thing.
Hey, if I may,
Okay.
right now, real quick, Dr. Joseph, have
Yes.
you heard of let me see, Somavedic, Somavedic?
No.
Okay, this is with electromagnetic frequencies. They've got devices that they've created to put in your office and put in your home to regulate and downregulate electromagnetic frequencies. And they have a lot of patient that it's absolutely helped. I think you're electromagnetic frequency sensitive, and they're one of the best. And there's another one that I'll get to you after I figure out, where they're at and so forth. I really think we need this in our office and we need this in our home. Okay. It'll like break up. And if you get shungite, if you wear shungite, put it next to your heart, and you wear shungite and you put it in your pockets and you put it in your office, it'll regulate the electromagnetic frequencies because they're off the charts. They're really off the charts. They're like radiation, and it's very intense. And I think you're sensitive, just like I am. And Patel had mentioned that to you last time. So I think this is a big part of what's going on with you. And if we can, I want to get, they have anywhere from, I think, $800 to $5,000 for high level gold, devices to low level devices. And I'll talk to Dr. Clearfield, and we're opening up a clinic right now in South Reno, and we're going to be working on this type of stuff. I think this is way huger than what all of us think. And I'm going to do my best to, get this type of information to all of us.
That's
Yeah,
a
Joel.
nice point that you brought it up, because there are EMF measurement meters available. So before you
Agreed.
jump onto the extensive stuff to buy it, you first find out what kind of a EMF you are exposed to, and which part of your houses or which part of your office has a high, because we are all surrounded by it. And then more chemicals and mycotoxins and the stuff, infections you have, they are the biologic factors which make you more susceptible to develop the electromagnetic sensitivity. But by lowering your load, you can do it. But the avoidance is the main treatment, and how to know that you are exposed to it or not. And so buy this meter. That meter is about $400, and if I have in my office, and we can give you the phone number, address, and you can get that meter and measure it. I think it's very important to measure it before you do the corrective procedures. And you can even find the patient is sensitive to or not by if you have an EMF free field, and then you bring the dictaphone or something to patient, and patient start having symptoms, that patient is the EMF sensitive. And then you can desensitize it. You can buy the equipment, all the different, even they have a night canopy to sleep at night, and you surround your bed with the canopy. There are things that you can put on your body. There are things you can wear as an undershirt, and so on. It can be a big full lecture, but I'm just giving you the few tips, and you can take on from there. I lectured it at a big conference, EMF conference in Santa Cruz, just a few years ago. And
Absolutely agree, Doc.
yes.
You can have mats underneath your feet. You
Yeah.
can have mats underneath your iPad, underneath your computer. You can have mats underneath your bed, and you can ground yourself the whole time. It's absolutely amazing once you start doing it.
Yeah.
Great.
Yeah, no, and that's a great point. And I'm always looking for the next level of things. And it's true that I became EMF sensitive. It was like a perfect equation. If I got into, say, a car, sat in the back seat of a, what do you call the cars that the popular electric cars? I can't think of it.
Tesla.
Tesla. Yeah, I mean, I could just feel the symptoms. It's like, here it comes. It was almost like bloating, brain fog, and it's like, and this heaviness and stiffness in my upper neck and shoulders. It's like, wow. I'm like, man, how am I going to deal with this new world we're in? And I can tell you though, or my ears will be ringing. But I can tell you, I have, as I've sort of started. Well, here's my main point. The cool thing is, just like with an Amlexonax, the purpose is not to say Amlexonax is everything. The purpose is to say, you know what, we're getting more and more targeted and refined with how we can modulate these dysregulations, and so that collectively, first of all, perhaps we won't have to be on 30 75 different supplements every day, but we can take fewer things, but we know exactly what we're targeting, and we're accomplishing more with like one treatment modality, and of course we use other treatment modalities, and like address EMF, and that we should go about the EMF with a similar mindset, that we're not necessarily shooting in the dark, or like you said, Dr. Patel, maybe we measure it to see, but we come at it with a targeted approach. We think about it the same way we think about how we're thinking about Amlexonax, and and what I have been doing has been helping dramatically. But Joel, thanks for bringing that up. I'm always happy to hear a new company or new approaches, and I believe that is very powerful as another piece of the puzzle.
I'll do my best to put the information, if you don't mind putting your information in the chat, I'll send you that, and I'll send you also another German company that has very powerful mobile and home processes to really remediate EMFs. I've been following it quite extensive. So if you don't mind, you can, DM me or whatever.
Yeah, absolutely. We've got the mastermind going here. So,
Amen.
We just take it all in and learn from each other, and it's a beautiful thing.
So let's finish up those little slides. What's left is all pictures. So just showing here, Amlexonax does inhibit the NF-κB or those kinase, and eventually it will inhibit the mTOR. And this is very important for killing inflammasome. Very important. This is anti-apoptosis. And so when you block the mTOR, you induce apoptosis, and you induce autophagy of the senescent cells, cancer cells, and inflammasomes. We know that Amlexonax activates the AMPK, which is very important to manage metabolic syndrome. In healthy cells, possibly Amlexonax as well as the KBV, they activate the mTOR, which help to stimulate the stem cells and the healthy cells. But in pathological cells, they inactivate the mTOR, and they lead to autophagy. So those are very important points, especially when we learn from KBV. We find out KBV does stimulate the mTOR in the healthy cells, so that's good for treating of retina pigmentosa.
But Dr. Lasha, please go back to the previous slide. Okay.
Yeah.
So if you look at this mTOR and you look this proliferation, migration, invasion, and
This is for cancer, yes.
Yes, these are all the factors. So you inhibit the mTOR.
Right.
Then
which is good to kill inflammation.
But whether it works in the same principle works in the tumor microenvironment is very important.
Right.
Because
So when
the cancer cell, this is on a healthy cell, are we talking, or on the cancer cell?
So we're talking about mainly cancer cells. The mTOR will be inactive, and AMPK is very good in activating the mTOR. And this is a mistake here. I think it's anti-apoptosis. And so if you inhibit the mTOR, you induce apoptosis. And you inhibit all of this in the cancer. So, and also in the inflammasome and senescent cells. So activation of mTOR, it's part of getting rid from the inflammasome, cancer cells, and the senescent cells. But I will argue that mTOR can be activated in the healthy cells. So there is a little bit different response, healthy cells versus cancer cells, the mTOR. And why? Because healthy cells, stem cells, you need to activate the mTOR to stimulate the stem cells.
Because in regenerative medicine, mTOR is very important. Because
right. So So it's different here. Our response, healthy cells versus cancer cells, inflammasome and senescent cells. And the response to those drugs are a little bit, could be opposite. Like curcumin stimulate the mTOR in the stem cells, but inhibit the mTOR in the cancer cells. You got my point?
Yeah.
Okay, so it's very important to know that AMPK is a very important molecule. I hope Dr. Patel, Dr. Yusuf will come up with a lecture on AMPK because it shows all the mechanism of action of exercise, fasting, all those things. It stimulates the AMPK. And AMPK, when stimulated, they stimulate the NFR2. And NFR2 is expressing the antioxidants, right? All the antioxidant enzymes is expressed by activation of NFR, which leads to detoxifications and antioxidant. But AMPK does stimulate NFR. And we know the AMPK, once being activated, you end up with increasing the mitochondrial biogenesis and health. You increase the proteolysis, which is very important to even kill the amyloids possibly and recycle that. So that's a good thing about the AMPK activation. It may helps in breaking down those bad proteins, which is prions, and also it helps increase the energy balance. We know that by activation of the mitochondria and increase the burning of the fat, right? And increase insulin sensitivity here. And this definitely slow the process of the aging, right? And optimize the health just by activating AMPK. And most of the polyphenols works by activation of the AMPK. Physiological free radicals that's induced by exercise activate the AMPK, which should definitely activate the NFR. Again, AMPK, it's very important. See exercise here, low AMP, which is empty batteries, activate the AMPK here. And it leads to the burning of the fat, right? Which inhibit the fatty acid synthesis, burning it, yeah, state of anabolism. So it increases the fatty acid catabolism, which is fatty acid, which is beta oxidation, right? And it induces autophagy by inhibiting mTOR or directly activate autophagy. And we know it inhibits the mTOR, right? And this will lead to autophagy and let's go to more about the inhibition of those protein kinases, the TBK1 and IKKE, which leads to inhibition of NFK. They did a randomized blind control study and they find it's working for managing diabetes. And we know why, because of the stimulation of the AMPK. And definitely when you stimulate the AMPK, you break down the fat, so you increase the lipolysis and the beta oxidation. So you manage the fatty liver here. Treatment of patient produced a reduction of hemoglobin A1C. That's how you know it's working. Trial also show that there was a reduction in the fructose amine. And this is very good because I think it's a promising drug for weight loss and for managing metabolic syndrome and decrease the inflammation. I think it's a good drug. I think Mike Beamer is doing 40 milligram versus 50, 3 times a day. 12 weeks use of it would definitely help to increase the insulin sensitivity and decrease the inflammatory markers. Giving this potential effect and long range of effect, amlexonax should continue to be explored with regard of its immunomodulator effect. We talked about it. And I think we are using it for asthma, right? And for diabetes and obesity and fatty liver. And I think all of this, we have studies and applications behind it. And we know that, you know, one of the hidden problems that we have is mast cell activation syndrome and liver fibrosis, fibrotic diseases. And I think this will help to manage those two pandemic hidden disease, which is mast cell activation syndrome and fibrotic diseases, where other drugs, they cannot really do much. And I think it's managing metabolic syndrome, right? All the 3 things: diabetes, mellitus, lipidemia, hypertension, obesity. And we need to have a serious investigation by you start using it on yourself and your patients and coming up with your results and feedback, as we see with Dr. Yusuf.
Do you think it will work on a biliary cirrhosis?
Yes, it does. It will work with biliary cirrhosis. In fact, possibly one of the biliary cirrhosis is also nonsense mutated genes. We're going to talk about it, but yes, it definitely helps the fibrosis in general because it does inhibit the Th17, but also it inhibits the fibrotic growth factors. So based on this data, anti-inflammatory agents, we can say amlexonax is anti-inflammatory, antihistamine, helps in metabolic syndrome, helps allergies, and it suppresses the chronic inflammation and diabetes and obesity and helps in metabolic syndrome, right? And we need to investigate. How investigate for you to start using this drug? I think the safety profile is very high. Dr. Yusuf is using it. And I think it will help your patients, and we need to learn from you. Again, AMPK, very important enzyme. I mean, then when you go to A4M, you hear about mTOR. mTOR is a downstream, and it involves, yes, in if you inhibit it, it definitely stimulates autophagy. But if you stimulate it, it will help to stimulate the stem cells. But this is our downstream of it. AMPK doesn't have the mTOR all the way. Okay, that's very important to know. And it stimulates the autophagy and those inflamed, and we know that it helps in burning the fat, right? Lipolysis, fatty acid oxidation, stimulate the mTOR, or directly stimulate the autophagy and increase insulin sensitivity and the glucose uptake. And this is very important for managing metabolic syndrome. Again, it's similar to NFKB. NFKB does the same thing. It inhibits the NFKB, the KVP or KPV, which is mineralocyte stimulating hormone peptides. And Amlexonax, both of them, they inhibit the NFKB, and both of them are very good. Adding to the NFKB, the KPV, which is mineralocyte stimulating hormone peptides, does have antifungal effect and antimicrobial effect. They make holes in those fungus and destroy them. So adding Amlexonax with KPV is a good idea. So you can get rid from the fungal infection and all those bad bacteria, because I don't see Amlexonax as antibiotic effect or prebiotic effect versus KPV does. So I will encourage adding to the Amlexonax KPV so you can get rid from the fungal side. And also it helps you to protect from the electromagnetic waves, because those electromagnetic waves, if they're on pathological level and constant, and that's what we exposed. And when we go to the conference with all this wiring or inside the car of Tesla, they open up calcium channel, and the calcium channel will lead to opening up the mitochondrial and release those free radicals pathologically, and you end up with pathological free radicals because of the electromagnetic waves. And you can buffer those and detox your body from those pathological free radicals by giving the Amlexonax. Amlexonax is good to prevent or manage oxidative stress from the electromagnetic wave. But if you have all other tools to measure it and prevent yourself from exposing it to those constant EMF, which is an oxidative stress agent or free radical generator machines. But again, there is you can create system that heals from the EMF if they are producing physiological level of free radicals. That's why we use EMF bed and all that stuff to as a healing. But if it's constant exposure, that will lead to pathological free radical, not physiological, and that will inhibit the AMPK. So physiological, those that healing ones, the EMF, do stimulate the AMPK because they generate physiological level of free radicals, versus the pathological exposure that you have in the Tesla car or in the hotels or resorts in Vegas, where they're being all the building wired, and you feel sick in it. And the reason, because of this constant exposure to the AMF, which leads to constant pathological free radicals that will inhibit the AMPK. So again, I can use both the Amlexonax and KPV, which is mineralocyte stimulating hormone peptide, in managing all this disease here: autoimmune, cardiovascular, metabolic, joint and joint disease, pulmonary diseases, neurological disease, cancer, right? And mechanism of action of metformin is activating the MAK. mechanism of action of berberine, polyphenols, all of them that activate the AMPK, and we see how the AMPK works in breaking down the fat and autophagy and helps to definitely kill the cancer. And it does stimulate the expression of antioxidant enzyme, and also it's expressed the NOS. So it does help improving endothelial function. I think Dr. Patel talked about it. And just by activating MPK, you can improve the endothelial function test. That's why how the polyphenols work, metformin works, Amlexonax works, the KPV work by AMPK. So I think we need to have a lecture of AMPK. And talking about it in detail. Again, we mentioned that Amlexonax, because it inhibits the NFK and NF-kappa B, then it's good for treating osteoporosis because you are inhibiting osteoclast. We know, osteoclast is a form of macrophage, it eats the bone. And if you can block that, and you block all those cytokines, especially interleukin 6 and all that, then you can decrease osteoclast activities and you can treat patient with osteoporosis. So it's a good thing, right? To add that in your equations. Again, I think this just shows you again the AMPK and the metabolic syndrome and how they are generated from activation of this IKKB, which is the NFKB, and eventually, and how this inflammation and all of this leads to activation of bacterial infections and all that stuff, leads to activation of this NFKB. And when you activate the NFKB, definitely you lead to insulin resistance and you lead to metabolic syndrome. And you manage it by blocking the NFKB, by blocking the IKKB, which is the which will inhibit the NFKB. Again, you see that the TBK and NFKB, NF-kappa B, all those kinases, definitely it turns or it causes the tumor to progress. Why? Because it stimulates the mTOR, right? And the mTOR will lead to proliferation, differentiation, and invasion, as you see it here. And it will lead to stimulation or release of those cytokines, especially the interleukin 6 and interleukin 4, and cause the polarization of the immune system away from Th1. And this will change the tumor microenvironment in favor of the tumor growth. And in addition to that, we know the stimulation of the TBK1 or the NFKB will lead to stimulation of the fibrosis, right? And all of this can lead to the tumor progression and invasion. And Amlexonax or anything that inhibits the NFKB will be helped because it will help to suppress all those bad inflammation, which is the Th17 inflammation, as you see it here. And it will help to possibly move the immune system to Th1. And also it will block the formation of the fibrosis, which squeezes the blood vessels, which prevent the infiltration of the lymphocytes from killing up the cancer. So that's the reason I think in addition of TBK1, it's part of management of cancer. So I can definitely give Amlexonax for all the patients with cancer, but I will add interferon gamma. I will add those immunotherapy, which is anti-PD-L1, anti-CTL4. I will add Avastin. All of this, I will add the metabolic therapy, redox therapy, photodynamic therapy in managing cancer. I will add losartan as well to really hit the cancer from all different directions, including low-dose chemotherapy. Again, this just shows you when the macrophage gets activated by the lipopolysaccharide from the bacteria, how this will activate those protein kinases, which is the TBK1, and that leads to increase the NFK beta here, and that leads to the expression of those inflammatory cytokines, as you see it here, which include interleukin 6 and leads to polarization of the immune system to Th17 and end inflammatory response. And to block that, you can just add Amlexonax to inhibit this those kinases, right? Again and again, this is a same thing. Just shows you how the inflammation start and how this inflammation activate the TBK1, maybe throw those toll-like receptors when they're receiving those bacteria infection, and how this will lead to activation of the interleukin-6 and polarization of the immune system into Th17 and all this inflammation that you see here. Again, for managing chronic disease, we recommend all of you doctors to be trained to load those drugs into platelets nanoparticles. Because if you do that, then you can get those medication to the pathology. And we have the training for that. I trained many, including Dr. Patel, Dr. Yusuf. They are here and they witnessed the effect of platelets nanoparticle. It's a very good tool. It does enhance, and then you can add everything inside your platelet nanoparticle. Let's say you want to do a joint, inflamed joint, osteoarthritis. You can add your oxytocin. You can add. We're going to have amlexonax sterile. You can add your losartan, and you load inside platelet nanoparticle. You can add procaine and oxytocin and all those drugs that you think will help in your joint. And it stays longer in the joints when you put it in the form of PMPA. Or you can put it, you can give the patient IV in case you're having cancer, or you're having, you want to deliver it into the brain. You can do it intranasal. You get those platelet nanoparticle delivering those drugs into the pathology, because nanoparticle size, in addition of packing those peptides and molecules and preventing it from being degraded when they are circulating in the blood, it stays longer in the body. And then because the pathology is leaky versus the healthy, so you can get those drugs going into the pathology. And other thing is that the platelet membrane receptors, they have this natural receptors that target the inflammasomes, the senescent cells and the cancer cells. So you have a specific targeting, not just passive targeting, but also an active targeting here. Again, you can also
please go backward and back.
Where here?
You mentioned about not this one, next one.
This one?
No,
one.
forward. You're going backward.
Okay.
Forward. Okay, here.
Here.
Yes, yeah. This injured blood vessels. So, what are you targeting here?
Well, when you have injured blood vessel, whether it's part of injury, even part of clot, if you have
Is it atheroma or something?
atheroma, for example, and you want to target those with the drugs that breaks down the fibrosis or helps to decrease the inflammation, so you can load your nanoparticles and it gets there and they start releasing into those injuries.
What do you load nanoparticles with?
What the drugs that we know that injectable that would help in atherosclerosis? Losartan is one. Okay, when we start having the injectable part of it, that would be a good one.
Actually,
what do you think?
Oxytocin.
Oxytocin will be good
for sure. Now, keep in
Right.
mind, I mean, the growth factors from the platelets, the platelet nanoparticles also have the growth factors. I believe that would help with. They have the
not
endothelial growth
necessarily.
factor.
The
Really?
platelets, yeah, the platelets growth factors. In fact, it's going to be another side of the sword. But it just delivering those drugs that of interest. Anything that helps to thin the blood. I don't know, curcumin. There is injectable curcumin. You can load it inside your platelet nanoparticle. May help to get them there and thin the blood. What other things that thins the blood and breaks down the fibrosis?
What about methylene blue and light therapy?
Yeah, I mean, methylene blue does work for everything. I will definitely add it in there, and anything that helps to break down fibrins.
Yeah, and acetylcysteine.
NAC will be a good, yes, NAC will be a wonderful drug.
Because that's going to help, because if we give a higher dose, that will help with clotting as well, and it will increase.
So losartan, NAC, oxytocin, methylene blue. If you want to, there's any streptokinase that is not as powerful that you can add, or anything that breaks down the platelets, that's curcumin, yes. But if you find anything that helps, maybe low dose streptokinase, maybe 10% of the regular dose, if you want to add it there, that you know that will not cause bleeding.
KPV peptide should help, right?
What peptide do you want to do?
KPV.
KBV will be good, yes, but not the, well, now it depends. The other one is BPC, BBC 157. Do we have injectable for that?
Yeah,
Because that it will help for patient who has blockage in the cardiac, angina, and they have atherosclerosis and narrowing, and you want to debulk collaterals because it stimulates what is the vascular endothelial growth factors, right? So
Yes, it does.
It does.
Yeah,
That's how it works.
It upregulates the gene of the injured cells,
Of the
upregulates
vascular
the
endothelial growth factor. So it helps the
yes.
building the collaterals. And that's exactly what you need for a patient with angina. And you have this blockage or atherosclerosis, which is fibrosis along with some fibrine and some plaque of fats. So we want to break the fibrosis. Losartan will be good. And you break it, you loosen it up, right? Along with KBV will be good too, because KBV and Amlexonax, if we develop injectable for this, that's our anti-fibrotic drugs, will help to open up those blood vessels, right? And loosen them up. And then you also want to build collaterals. And I think the BBC 157, if you have the injectable one peptides,
yeah,
will help
yeah,
to build
we do.
up the collaterals. Yeah,
Yeah.
so I think those are things that you need to be critical thinking, and just don't use the big dose. Just use 10-20% in the beginning and see how the response is, and then you can go from there. All the time use low dose because you think the platelet nanoparticle will enhance the delivery, get to the pathology, so you still get the effect. And then if you use the full dose, you may have any side effects that you don't want. So use just 10% of it and still you can get the results. If you want to do stem cells, and we do that, me and Dr. Joseph James, we train people to do fat cell or fat transfer. And during the process of fat transfer, when we do the
So you
micronization of
give
the
the stem
fat,
cells in the nano,
you can, when the process of the training,
or
when we
exosomes are better than stem cells.
you
right?
can do exosomes if those stem cells are stable enough to stand the sonication and the nanofiltration, that's fine. But these in fat stem cells that when we do the fat transfer and we do the micronization of the fat and we inject into the face, those micronized fat, they're white, right? You can ultracentrifuge it, like putting it in 5,000 round 10 minutes, and you can get all the stem cells being squeezed in the bottom. And then you can take that and you can sonicate it and add drugs if you want to use fat-derived stem cells and use it as a nanoparticle to deliver drugs. So during the fat, well, we don't really, when we do the training, we don't want to say we're doing fat stem cells extraction. We say we're doing fat transfer for cosmetic procedure, but down to while we're doing that, you can take those micronized fat, and because they're being broken, those stroma, and release those stem cells, and you can just centrifuge it and you can get the stem cells and you can use it for treatment if you want. Again, this is also from the stem cells that can be used the same thing like we do for platelets, but platelets are more cheaper than stem cells. So it's not that wise to use the stem cells if you have the platelets for delivered drug. It's more cheaper than stem cells. But if you want to be creative, in other words, you want to do extra things.
Exosomes have the membrane too, right?
Stem cells do, yeah. So we can use stem cells. And
Right, but what about exosomes? Stem
exosomes,
cell-
well, exosomes will be also good. The question is that are they strong enough to stand the sonications and nanofiltration? I don't know. So, but it's a
but
good thing.
better than stem cells are not. They are more
Right. So basically, why we don't just skip the sonication or do sonication, but do a little of sonication, not why, just to mix drugs, sonication, not to break down the exosomes, and just go with the nanofiltration, but the extrusion process, and the extrusion itself would push those drugs into those exosomes by diffusion. So just don't be fast with them, those exosomes with sonication. Do a little sonication just to mix the drug, not to break them, and then do more of nanofiltration.
I don't know if this will help, but Dr. Clearfield adds BPC 157 to his semaglutide with, I believe it's vitamin B6, and that gets rid of the nausea. So I don't know if you guys can work with that, but that's what he's done. And it looks like we're having dramatic results. We got one Army veteran who lost 36 pounds in 6 weeks, no nausea, no nothing. and he's doing great. And I think it might minimize the thyroid cancer possibility of thyroid cancer. I don't know if that'll help.
Let me tell you about that. I will not get BBC near to the cancers. And the reason, because it does stimulate the vascular endothelial growth factors, and those one push the immune system to Treg.
Right.
And it has the which we need to, that's why we give Avastin, which is the opposite of what BBC will do. So very important that we know what we're doing with cancer and not putting peptides that may aggravate the cancer. I believe BBC is one of them. But nausea and vomiting, all that stuff, it's good as an anti-inflammatory. Yeah, that's okay. You got my point?
Yeah, definitely.
Right.
Thank
Okay. So we're good today. Again, I will invite you to attend the Chronic Disease Prevention Management weekly webinar, 7:30 p.m. every Monday. Please attend it. And we're going to repeat this in our session. This is the first, by the way. He got the first lecture, Dr. William, of Amlexonax. So he's the first, even before our Mondays. So we, my group, they don't have, I mean, it will be new for them. But if you want to join me and add to this, we're going to repeat it again in my session. And I think we're done. Any questions? It was a long lecture, right? 10:30.
I think
I
we
do have a suggestion.
Go ahead.
Go ahead, please.
Ahead,
Dr.
Dr.
If James and I have been working on my leg, I have a partial blockage of one of my, or I did have a partial blockage of a blood vessel in a leg. Probably I felt due to scar tissue from an injury. And we treated it just using orals. Because we had time, I was not particularly symptomatic. I had monophasic flow in it. It was very narrowed. We used serapeptase and endocalyx pro, which improves the glycocalyx, and red light therapy, and also Amlexonax for any inflammation. I had several things so that I could not get back into his office. I went to his office, and I had been treated for about 3 months, and I now have multiphasic flow. He wouldn't commit to whether it was biphasic or triphasic, but it sounded triphasic to me and looked triphasic to me, and so that blood vessel is now open, and he wouldn't even dream of treating it. He was thinking of stenting it before. So there's an oral treatment with red light, which worked very well.
Oh yeah, I mean the light therapy does increase the nitric oxide and helps improve the endothelial function, and a light therapy is amazingly. And if you add the McCarran Blvd and you add all the tools that you have, I mean, come on, Dr. Yusuf James, I will consider him right now, and along with Dr. Patel, they are the frontier of medicine, and things that they have, it's the top.
So I have a patient with PVD and has a stent, but he probably has the atherosclerosis everywhere, although may not have symptoms. So I am treating him currently, but I thought more can be done. So you think the McCarran Blvd can help with the red light therapy?
Along with Amlexonax, along with the KPV, along all of this, just because those are antifibrotic. And atherosclerosis is not just removing the clot and removing the.
No, it is atheroma.
It's atheroma. It's fibrosis. So those KVP and Amlexonax are the best antifibrotic. I mean, we saw that it's good for liver fibrosis, and so if you added this and along with the light, which improve the endothelial function test because it will improve the increase in nitric oxide.
He has a hypertension, so I have to be very careful with the McCarran Blvd.
Yeah, just use low dose and you're okay. And then with light therapy and with you do losartan as well.
Nano treatment would help him any more than the
I
non
think it's better to particulate it to get those medications in, especially if we get the injectable losartan in, but you can still use oral losartan, 5 milligrams, see how that works. I mean, whatever he does with hypertension, just switch him to losartan. Whatever what he has in hypertension.
he is on 3 medications.
Yeah, you said one of them is enalapril, right? That one you can switch them with lisinopril because that's what we do when we have any side effect with lisinopril. We switch them to ARB,
Yeah.
and the cardiologist will not be upset from that. And just
Yeah, I was
keep
gonna
taking it.
add something. My mother had mentioned Dr. Dell. Well, first of all, I mean, her vascular surgeon, of course, he wanted to do a stent, but I thought otherwise, and she thought otherwise too. Once we were able to show that she could get a pulse with these modalities, but I just wanted to add another thing that we could talk to into the future, just something to not a mystery or, but she was talking about the endocalyx and glycocalyx. It's actually the active ingredient is actually fucoidan, which is a very powerful condensed Japanese, I believe, Japanese seaweed that happens to modulate or upregulate sirtuin 6. Okay, so what I'm starting to see another pattern and things to look into is, are we turning on certain sirtuin genes, and this kind of is close to AMPK as well, because I think once we get these sorted out,
Joseph, isn't that the NAD turns on the certain genes? If you give NAD, IV NAD,
and
it does have a
not
certain genes.
not sirtuin 6. It's sirtuin 1. I think 3 and 7. Don't quote me, but not sirtuin 6. Sirtuin 6 is very difficult to activate, and that one is involved with DNA regeneration and fixing of the DNA. So in cases of microcirculation that has been damaged to a certain point, there needs to be a regenerative, that's where we get into the other leg of the pillars of chronic disease. We got the redox, we've got immune, we've got the metabolic, but then we have to upregulate regeneration and fixing of the DNA. And that's my understanding. I'm just saying this is just something to add. We can go into in depth into the future, with multiple articles in pathways to demonstrate what we're talking about. But we're talking about microcirculation, and there's actually been they did a study on COVID patients in the ICU, showing that there is a direct correlation between the condition of their overall condition of their microvasculature, which can be measured, and their mortality. So you can imagine that the microvasculature, which is really where the endocalyx lies. So the endocalyx are the sort of little hairs that that are involved with the microcirculation and function, that we lose those with microvascular disease, and especially if we're having like little microclots. That's another arena to look into. And obviously, and my mother, we also injected PRP and with oxytocin into the scar tissue as well. That was another thing that we did. So anyways, that's what that's all about. So yeah, fucoidan, sirtuin 6, and I'm glad you brought that up, Dr. Patel, because yeah, NAD turns on, especially SIRT1. But I think at some point we should have a learning about the sirtuin genes in general, since they are the master regulators, ultimately the master regulators of metabolism, inflammation, and regeneration. Longevity genes that if they're turned off, well, then the aging process speeds up.
Right.
Can I ask a question or make a comment?
Sure.
Well, when you have exotic birds, like a parrot that lives for 33 years or a cockatiel that lives for 20, fatty liver disease can kill them. And it's painful to lose them. And when we went through this, our vet recommended lactulose. And I'm thinking that Amlexonax might be good with it or better than it. And then when you have a large dog that you love very much, they can get hip dysplasia. And Dr. Sylvan talks about hydrocortisone, and maybe Amlexonax might be worthwhile in that regard, other than also the Aussie my daughter has now, it swims a lot. So I wanted to mention that. And the other comment going back is for liver spots on the skin or age spots, this might be a panacea to some extent.
Are you talking about Amlexonax being a potential treatment for age spots on the skin?
Yeah, age spots, liver spots, and, you know, certain creams, whatever. But, you know, blood thinners can mess up your skin too. And
Yeah, I
cause
mean,
spots.
that's a good question. Now, I can say, because I do have a cosmetic background, that, you know, when the certain spots on the skin, they may require, you know, some sort of a laser sort of shattering of the pigment to get rid of it. But then, of course, preventing it from happening, I could see how the pathways involved with Amlexonax may be playing a part. It sounds like redox is really important. I know that vitamin C helps as well, because redox is a part of melanocyte overexpression if there's too much oxidative stress. I do know that one for sure. But yeah, some of these spots, they need to be broken up, like shattered, in order to get rid of it. But yeah, I think but yeah, in concert with some of these other strategies makes sense.
Well, you know, losing a pet is not a pleasant thing to go through. So that's why I mentioned the birds. And, you know, our daughter had her first Aussie that only lived till 7 years old. And she was able to keep him alive through periodic, you know, couple blood transfusions a week. So that was not fun.
Yeah, and that's why I love that lecture that there was a veterinarian that gave a lecture a couple months ago, which was fantastic. Basically utilizing all of the things that they're using at wellness centers, hyperbaric chamber, even pulse electromagnetic frequency. And yeah, I mean, I have no problem with giving my mother's dogs, you know, some of the peptides. You know, if his hips hurt, we've given him BPC 157, I think TB 500, and actually had him lay down on the pulse electromagnetic frequency
cool.
bed, and literally he could literally walk and run around better and jump around and go up and down stairs like dramatically better. So yeah, we can use these treatments on dogs. They've got the same, you know, basically the same molecular chemistry as we do, as far as I know.
Where the dogs sleep at night is very telling. You know, they sleep in the bedroom or on the bed often. Yeah, they are people.
Yes, they do. I've got. Do you want to? Are you ready for questions, Dr. Alaza?
I'm open if there's any questions. Yeah. So if not, then
Yeah,
Yeah,
no,
go
we got a few questions. Looking through right now. Let me see. Number one is, let's see, what kind of contraindications that you know?
Allergy, allergic reaction to it, like any other drugs. So that's the only thing that's been reported. It's very safe. It's been used since 1993 up to now. There's nothing being reported that's alarming.
Okay, so Amlexonax is a comolin sodium mimic or vice versa.
Is it what?
It says so Amlexonax is a cromolin sodium mimic or vice versa.
It came from this mass stabilizer, chromoglycan, or cromolin, but it's modified. It's not completely same. It just, but it came from that drug.
Okay, and Dr. Joseph, what dosing did you use on yourself?
Yeah, great question. 40 milligrams 3 times a day is needed. So 40 milligrams is the dose that I used, that I still use.
So you mean you as needed means you didn't take it every day?
Well, I took it every day, yeah. But you could use it as needed. That was the original script, but I felt better if I took it 3 times a day, especially because allergies were just ridiculous over
Well,
the
I don't know
past.
if it's okay for you, but Dr. Joseph, you have psoriasis as a background of multisystemic disease, and this is, if you take it every day, you're justified to take it every day. But for people with anti-aging or healthy people, they can take it as needed and possibly just take it per week, twice a week or something, just to give that break of cycle. But people have
Yeah,
generally, and when they have underlying inflammatory diseases, I'm okay with it. Yes. Any questions? Yeah.
Yeah, Dr. Stoker asked the prostaglandins.
Mhm.
I'm not sure what that is about.
Prostaglandins, what's happening?
oh, with all the landings, he was just being funny, I think, with the echo.
Okay, got you. And then Dr. Beamer said, very interesting drug. Thanks, Dr. Alasa, Dr. Joseph for the info, and Dr. Clearfield for hosting. I have Amlexonax. I needed to give me a text, and I will get any info you all need. 321-301-0752. Okay, so, got it. Try now. Is there any Benadryl link to dementia? Ara Fitz.
What is that? Is there any?
Is there a Benadryl link to dementia?
There is some study about Benadryl used for a long period of time. That's why, you don't use it all the time. But people with allergies, they're using it all the time. And there are studies about, because it has anti-muscarinic effect, that may lead to dementia. But at the same time, there are studies in Harvard Medical School and others that is good for preventing cancers. So it's a sword with 2 edges. I would recommend using it per need and not religiously to break the cycle of any harm that's coming from it.
Okay, double question from Laura. Did you try giving your gut a rest and support in Dr. Terry Wall's protocol? Mitochondrial support, I would think would help. And she put a link in the chat.
Of course, anything that helps to stimulate the AMPK, which is all those, everything actually goes, most of the time, activate the AMPK. Polyphenols works to AMPK. I will recommend adding whatever helps to stimulate the mitochondria. That's good.
Sorry. No.
Okay. Certified herbalist, give me nettle parsley mix to drink. It worked. Okay, that was Dr. Maura Fitz. Shellstein, c4st.org. She put that in the link. Maura Fitz, send it to me, Joel. Okay, got that. Blah, 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 blah. Somavedic. Okay, that's me. Shellstein, EMF, Joel, you to everyone. Okay, so I'm trying to find the solution. That's me. Let's discuss this later. Shungite, Maura Fitz, fascinating. Where are these doctors based? The drug doesn't exist on GoodX. Okay, Clearfield and Reno,
Can answer that. Yes, but it's not a good reaction because it's compounded.
Okay.
The Amlexonax.
Okay, long-term steroids destroy everything, skin, eyes, bones. Can it help reverse?
Yes, if you activate the AMPK by Amlexonax or polyphenols, I think it will help.
Okay, thanks, Dr. Halassa. Excellent as always. Dogs are people too. Dr. Stoker, Pavlov, yeah, agree. Just had to put my service dog down, who used to be our mascot at Dr. Clearfield after 16 years. That was so hard, even as a Marine. Shellstein, Pavlov had it wrong. It's the dog that conditions the master. Amen to that. Dr. Stoker, he needed it every day. So it looks like we're good.
Okay. Do you know this is the longest lecture, 2 hours and 34 minutes.
Amen.
Uh,
Absolutely.
okay. Well, great. Well, hopefully we'll have a center in Hawaii, right, Dr. John? Are you still working on that?
Or the Bermudas. I want the Bermudas. I'm just saying. I'm just going to interject. Go ahead, Dr. Burgess. It's all yours.
Well, we're working on anything goes right now. We're just looking on ideas. West Coast, East Coast, any subject, any place. So Florida's possible. And if you guys, if we want to get just a little bit rich, we might want to go to the Bahamas, but wherever we go, we need to be careful.
Well, I have a group. They have 8,000 square foot. They are people with top doctors. Possibly they want me to run that center. And if I do, then I will bring my people to be there, like Dr. Patel, Dr. Joseph, you. Possibly if we can create a model of what we're doing, including Dr. William. I mean, he's the whiz in metabolic part of the chronic disease prevention management. And Dr. Patel in the cancer thing and her immune modulation, with Dr. Joseph, I think he covered all the topics. If we can create the model, then we can replicate that model everywhere. So
Are you talking about the Bahamas?
no, I'm talking about Florida. There's a group,
Okay.
they have 8,000 square, and I'm going to be there in Florida next week, attending their conference, speaking there actually. And then I'm going to be in the beach. I have a condo there, so if you want to come and have fun on Sunday and swim with us, because I have a lot of meeting with those business people, possibly the guy who's putting a big center near to Orlando, the 280-acre medical center and condos and resorts and all the good stuff. I'm going to meet him again, and he's interested in our model to create the protocols for his medical center that he's building up. There's a lot of potential. Everything is still in the air, but if we land on something, then we can replicate it and we can work together on it. But without having a model on the ground with CDPM and what Dr. William is doing and what you're doing, and having all this joint force in one place and that replicated, it's going to be difficult because it's just we are everywhere.
Okay, well, let's communicate.
Okay?
And not on that, let's reach out to physician assistant Hartman. He's in Florida. He could probably help with this whole process, and I'd love to get there myself. Just saying.
Well, if you want to meet me there in Florida having fun, anyone, but maybe Stefan will come because it's not far away. And me and Dr. Joseph James, we're gonna have 4 days with Dr. Klatz. The
Really?
bro meet, and in the swimming pool. I mean, in Hyde, the Hyde condos. I mean, those are one of the top ones, right?
Where is this?
There. From June 14, 15, 16, 17, 18, 19. So 14 to 19. But Sunday.
You said it's Orlando?
It's in the Hyde and the Hollywood Beach next to Dr. Klatz.
Oh, Hollywood. Yeah. Okay.
Yeah. In case Sunday, if you don't have anything, just come and have fun.
Yeah, sure. You can do that.
Anybody wants to meet us there, welcome.
Yeah, I can do that.
Is that good?
We're going to stop
Yeah.
recording.